We are live.
A very good evening, everyone. Welcome to the online iFocus series, lecture 4 to 8 of the Cataract module. Today, the topic of discussion is surgical repositioning and explantation of intraocular lenses. For the session today, I would like to welcome our moderator, Dr. Prafulla Kumar Maharana, sir. Sir has done his MD Senior Residency in Cornea, Cataract and Refractive from RPC AIMS, New Delhi. Sir is also an additional professor at RPC Center, AIMS, New Delhi. Sir is also the current secretary for Delhi Ophthalmic Society. Sir is the chief editor of Ophthalmology Clinics 2, and postgraduate ophthalmology book series. Sir has published over 395 Google Scholar and 156 PubMed Index papers with over 50 chapters in national and international books. Sir has won various awards like the Best Surgical Technique Award from Ransco, Young Achiever Award at ISCKRS, Ajit Babu Maji Award, and awards for Best Paper in various conferences. Sir has been the principal investigator in 2 ICMR trial, 4 PI in 18 trial, including 2 multicentric international trials. Welcome, sir.
Thank you, Garvita. Good evening, all.
I would like to also welcome the chairperson for the session, Dr. Neeraj, sir. Sir has done his MBBS and MD from AIMS, New Delhi. Sir is currently a senior consultant at Center for Sight Eye Hospital, Ajmer. Sir is also the Vice President of Rajasthan Ophthalmic Society. Sir has served as the Chairman Scientific Committee of Ajmer Ophthalmological Society and the Organizing Secretary for Rajasthan Ophthalmic Society Conference 2013 at Ajmer. Sir is one of the pioneers in phacoemulsification surgery in Rajasthan. Sir has participated as faculty in various life surgeries in phaco and SICS workshop and has multiple presentations as faculty in various ROS conferences. Sir has various scientific papers, surgical video and instruction courses to his credit in various national and international conferences. Sir has also received gold medal for distinguished services in ophthalmology by Government of Tamil Nadu in IRSI conference in 2014. Welcome, sir.
Thank you. Thank you for the introduction. Good evening, everyone.
Finally, I would now like to introduce the speaker for the session, Dr. Nikita Gupta, ma'am. She has done her MBBS from Maulana Azad Medical College, MD from AIMS, New Delhi. Ma'am is also the first female MCH vitro-retina person in India, which is from PG IMR, Chandigarh. Ma'am has also FAICO in retina and FICO in uvea to her credit. Currently, ma'am is an associate consultant for Center for Sight New Delhi and has presented many papers and posters at national and international forums. Ma'am has won many regional, national, and international ophthalmology quizzes and won awards at various conferences. Ma'am has published various papers in index journals. She is also an esteemed member of all national ophthalmic societies like VRSI, USI, and also URetina. Welcome, ma'am.
Thank you.
I would like to invite the speaker to please share the slides and to begin the class now.
Is my screen visible?
Yes, ma'am.
Can I start?
Yes, ma'am. Please.
Good evening, everyone. First of all, I would like to thank iFocus for giving me this opportunity. And without further ado, I would like to start my lecture on surgical repositioning and IOL explantation. I have no financial interest. So, what is the indication of an IOL repositioning surgery or an IOL explantation surgery? The most common indication of an IOL repositioning or explantation is an IOL dislocation or a decentration, which could be a toric IOL, which is off axis, or a decentered multifocal IOL, or a single piece IOL with its haptics out of the capsular bag, or a decentered sulcus placed IOL or a scleral fixated IOL. The second most common reason for IOL repositioning or explantation is a refractive surprise or an incorrect lens power, as we have recently seen the case of popular actor Shah Rukh Khan. The other common indications are IOL opacification, a damaged IOL glistening, a patient complaining of dysphotopsias, or other complications related to the IOL, which could be a UGH syndrome, pseudophakic bullous keratopathy, any retinal problem, retinal detachment or a break, or a cystoid macular edema. This is a survey which showed the most common reason for explantation of a one single piece monofocal acrylic IOL was a dislocated or a decentered IOL, followed by incorrect lens power. So what do you mean by a malpositioned IOL? It could be a decentered IOL, which means that there is loss of IOL centration. That is, the IOL center does not coincide with the pupillary center, but there is no zonular or capsular instability. The other thing is subluxation, where there is partial zonular or capsular instability, and you can see the IOL optic in the pupillary axis. The third is dislocation, where there is total zonular or capsular instability, and the IOL is either dislocated, that is from its position, either anteriorly or dislocated posteriorly into the vitreous cavity. These terms are, however, used interchangeably. Now, what are the signs and symptoms of a malpositioned IOL? Now, what does a patient complain of? He complains of decreased visual acuity. There is glare, which could be related to the edge of the IOL optic. The patient could complain of monocular diplopia, that is seeing double images with single eye. And he could also complain of floaters in cases of dropped or luxated IOLs. And what are the signs that would point towards a malpositioned IOL? One is, of course, a drop in visual acuity, an astigmatism not explained by the corneal curvature, a corneal edema, which could be related to the IOL placed anteriorly, increased IOP, which could be again being seen in anteriorly subluxated IOLs, leading to pupillary block glaucoma, or in cases of dropped IOLs, there may be retinal breaks or retinal detachments. Now, the incidence of IOL exchange has actually decreased over time. It was about 1.75% in a study from 1986 to 1990 and has now decreased to less than 0.53% in a recent case report. However, the indications of IOL exchange have actually changed. Earlier, people used to get exchanged for complications of IOL, like PBK or glaucoma. However, now the patient's expectations have increased since we have now have premium IOLs, and the cataract surgery techniques have also advanced. So patients want an absolutely perfect surgery. So therefore, the indications of IOL exchange are now more when the patient is dissatisfied with the IOL. So what do we need to evaluate before we plan an IOL repositioning or an exchange? What do we need to know? The first most important thing is, when was the cataract surgery done? And what was the method of cataract surgery? Was it an SICS? Was it a phacoemulsification? Second is, we need to know the best corrected visual acuity of the patient. Whether if the IOL is the optic is out of the pupillary axis, we need to see whether the best corrected visual acuity is improving, and only then we'll plan the IOL. Third is a corneal status, which is very important for any surgery in the eye. So we need to do a specular microscopy, look at the corneal thickness, and look for any corneal opacity. The intraocular pressure, of course, is very important. The most important thing is, of course, the capsular support. We have to look at the status of the posterior capsule and the status of the sulcus. Only then we can plan what IOL we need to implant after removing the pre-existing IOL. The presence of vitreous and wound or AC anterior chamber is also very important, and we need to plan the need for vitrectomy and the anterior vitrectomy, or also have a retinal surgeon backup. The type of the IOL in the eye, of course, is very important, because we have to see whether we can reposition the same IOL. We need to have a small incision to get we need to have a small corneal incision to get the IOL out, or we need to have an SICS tunnel to get the IOL out. How much is the IOL covering the pupil? So we need to see the pupil in the undilated state, and we need to see how much of the IOL optic is covering the pupillary axis. The biometry, of course, is very important to plan what IOL we need to implant in the eye, and especially if we need to do the biometry in the pseudophakic mode if there is already a pre-existing IOL. The retinal status with the periphery examination has to be done before any IOL exchange surgery, because we need to see if there is any pre-existing retinal break or anything that can contraindicate that will affect what IOL we'll place in the eye. And of course, the presence of cystoid macular edema will also dictate the timing of the surgery. So therefore, we have to have a set thing in mind. We have to plan what surgery we're going to plan, how we're going to remove the IOL, which IOL we're going to implant, what are the difficulties we'll anticipate when we'll be removing that IOL or repositioning the IOL, and what are the precautions that we have to take to minimize those difficulties. And the most important thing is how we counsel the patient. So very important for any surgeon who takes up this patient for IOL repositioning or explant is to counsel the patient very well. We have to tell the patient what condition is already there in the the eye, why are we doing the surgery, what he can expect, what are the complications that we can anticipate, and any other everything that whatever IOL we have to keep as backup, everything has to be explained to the patient. So what are the techniques of rescue, repositioning these IOLs? One is, of course, the IOL rescue or reposition, where we preserve and reposition the same dislocated or decentered IOL. And the second is IOL exchange, where we remove the pre-existing IOL and insert a new one. The type of the technique we are going to imply will definitely be based on the eye anatomy, which is the capsular support, the status of the posterior capsule and the sulcus, and the type of the IOL which is already placed inside the eye. So the IOL exchange, for the IOL exchange, if there is a good capsular support, we try and place the IOL in the posterior chamber or reposition in the ciliary sulcus. However, if there is a weak capsular support, the options are an anterior chamber IOL, a scleral fixated IOL, or other iris fixated IOLs. So let's go to the first scenario where we have to remove where there's a single piece monofocal IOL in the eye, and the patient comes in the window period of 4 to 6 weeks after his cataract surgery. So in these cases, these are relatively easier cases because here the lens has yet not formed fibrosis with the bag, and we can easily open the capsule by viscodissection. Now, this is actually a surgeon's preference to do it in topical anesthesia or local anesthesia. However, I would say as a beginner, you should always do it these cases in local anesthesia because we're going to do a lot of manipulations of the iris, and we don't want the patient to be in pain and squeezing his eye frequently. So before going into the steps, let's just look at this surgery where this was an IOL, which was it was a monofocal foldable IOL placed in the bag just one day before this surgery was done. And when the primary surgeon placed the IOL in the bag, one of the haptic was broken and was left in the inserter. So only one haptic with the optic was placed in the bag. And we had hoped the IOL will stay. But in the first pre-op day itself, the IOL had sunk, subluxated. And though it was in the bag, it was covering only half the pupillary axis. And the patient had to be taken up for IOL exchange. So we can see whenever we are doing such fresh cases, we should try and reopen the same previous corneal incisions. And we can do that with a BSS filled cannula, or we can, if we are not able to do that, usually we'll be able to do that if the case has been done in the last 1 month. But if not, then we should not try doing it with a blade, rather make a new corneal incision. Now the technique is to put a lot of OVDs inside the eye, especially below and above the IOL, so that we have an inflated capsular bag. And then with using a manipulator or a Sinskey hook, we should try rotating the IOL or lifting the IOL out of the bag into the anterior chamber. So the surgeon is using a VY and a manipulator to rotate the IOL into the anterior chamber. Then you have to again insert viscoelastic over and above the IOL, usually a viscodispersive viscoelastic to protect the endothelium as well as to keep the bag inflated. And then we have to, now the technique to remove the IOL out of the eye can be, the most common technique is actually bisecting the IOL using a IOL cutting scissors. So this surgeon has actually first cut the haptic out of the optic, and now is trying to cut the optic into two. So we don't have to divide the whole of the optic into two. We have to cut at least half of the optic. That is at least up till the radius. So you can see from the main incision only, the IOL is divided into two. And again, in between, you should always remember to keep the endothelium and bag protected. So keep putting the viscoelastic again and again in between. You don't have to do it in one go. Then again, using the manipulator, you're stabilizing the other edge of the eye of the optic, and then cutting because if you don't cut it at least up to half, it'll be difficult to get the optic out of the eye. So it's better to cut the optic at least 50%. So we can see the IOL is being cut into half, into the half of the half of the diameter of the optic. And then using you can use an IOL cutting scissor for the same purpose, or you can also use a Vanna scissor. But you might have to extend your incision a little if you want to use a Vanna scissor. And then using a McPherson forceps, the part of the haptic was removed right now. And now the optic is held, and then it is rotated, and the optic comes out easily through the corneal incision. Again, you have to put a lot of viscoelastic to keep the bag inflated at all times. And since this was just a fresh case, the PC is absolutely intact. So another IOL, a foldable IOL, is replaced in the bag. So this is another single piece monofocal IOL into the bag. So this is how you do in a fresh case. So you have to open the previous corneal incisions, inject a lot of OVDs into the bag, lift the or rotate the IOL out of the bag, divide the lens into half, and then pull out the halves through the main incision. And of course, have an ice inflated bag in this case, but in case your bag is not intact or you have a PC rent, you can put the IOL in the sulcus. So the most common method, as I said, is bisecting the IOL in the AC and pulling the two piece out through the corneal wound. As I said, you might have to enlarge your 2.8 mm incision to maybe approximately by 3 or 3.2 to get the IOL if you're using a Vana scissor. Now, the other technique is the twist and out intraocular lens removal technique by Uday Devgan et al., which was published in JCRS in 2020. It's a very interesting technique, though although I have not used this. But this technique says that you have to it's done in a similar way, but the advantage it says you can get the IOL through the 2.2 mm incision only. So you get the IOL similarly into the anterior chamber by putting OVDs anteriorly and posteriorly. Sorry. Hello.
Yes, ma'am, you're audible, ma'am.
I think there is some problem from her side.
Yes, sir.
I am not sure why it is not moving, but I think so. So basically, the OVD is placed above and below the IOL, and then they use a spatula to protect the endothelium, and which would also help in rotating the IOL. So the technique is to rotate the IOL around the forceps, and then is the video working?
Ma'am, the video is not playing, but you are audible now, ma'am.
Am I audible?
Yes, ma'am.
You can
You're audible, ma'am.
you can go to the playing mode at the bottom. If you see there is a arrow. If you go and click there, I think the video will play. In your slide, if you see there is a play mode arrow on the corner, left side corner. You just go with your cursor there and you have to come down to the left down side. There is a arrow there. Yeah, here. This arrow, if you
But is the audio video working?
Yes, ma'am. Now video is
Oh,
working,
now-
ma'am.
Yeah. Okay. Yes. So as you saw in this technique, in the last technique, a twist and out technique, they put a forceps inside the eye, hold an edge of the optic, and with their hand in the supinated position of the hand of the surgeon is in the full supinated position, and then the surgeon pronates his hand 180 degree, and then again supinates as much as possible, almost a 300-degree turn of the hand around the IOL, and this way the IOL wraps around the forceps, and then the surgeon pulls out the forceps through that 2.2 mm incision. So you can basically through a smaller incision, they say that you can pull out the IOL without having to cut the IOL and having special IOL cutting scissors. So that is the technique described by Uday Devgan. So the next scenario is when the IOL has to be explanted after around 1.5 to 2 months after the cataract surgery. So the major issue in this scenario is that there is fibrosis around the lens already that has happened, and we have to deal with this fibrosis. So removing the lens will not be that easy, and especially the haptics would have already flared out and embedded in the bag. So in most of these cases, we have to cut the lens at the haptics and leave the haptics fibrosed in position in the eye. However, the previously placed IOL is a three-piece IOL with the thin haptics. We might be able to rotate those haptics out of those groove. But for these other Alcon and Technis one-piece lenses, the edges are flared out and they have embedded in the bag, and we are usually not able to get the haptic out. And we should not even try to pull these haptics out of the bag, because doing so has a higher chance of creating zonal adhesions, and then we might ruin our chances of putting another IOL in the eye. And in most of these cases where we are explanting the IOL after months of cataract surgery, we should prefer a sulcus IOL, that is a three-piece acrylic monofocal IOL. But of course, we should keep an AC IOL handy in cases of zonal adhesions or inadequate residual sulcus. So let's look at this surgery where there's an opaque IOL and so the surgery is done because there's an opaque IOL, and patient is complaining of a curtain in front of his eye. Although the vision is 6/9, but the patient is just not comfortable. I don't know why this surgery is not working. The video is not working. Okay, I'll then just describe the point. So in these cases, we need to make new corneal incisions, of course, because they are old healed incisions. We again inject a lot of OVD into the anterior capsular bag above and both below the lens, and usually a viscodispersive OVD. And then we again try to lift or rotate the IOL out of the bag without disinserting the zonule. Am I audible?
Yes,
Yes,
ma'am, you're audible.
But the video isn't working. Okay. So we get the IOL out of the bag. So we cannot get the whole of the IOL out of the bag. So we cut the IOL at the optic haptic junction and leave the haptics in the bag. So with the IOL haptic out of the bag, we sandwich it with the OVD over and above on the top and bottom. And using a lens, so we can use a Sinskey hook or a manipulator to stabilize the lens, and then or lift the IOL, and then use a scissor to cut the IOL IOL optic the same way as we've discussed, and then pull out the optic through the main incision by rotating the IOL. And then we inject a lot of OVD in the sulcus to make space for the new IOL, and we orient. So now when we insert the IOL in the sulcus, we have to make sure that the haptics of the new IOL are 90 degrees away from the residual haptics of the old lens that we have left, because otherwise they'll push the lens anteriorly and cause some refractive error. So therefore, we should try and placing the new haptics perpendicular to the old haptics. I'm sorry the video isn't working. I might show another video in the end. So the next scenario is when there's a PMMA IOL in the eye. And these PMMA IOLs are non-foldable IOLs. So we have to remember that PMMA IOLs, we cannot cut them. So we have to explant them as a whole. And the best way to explant them is through a scleral tunnel. We can also explant them through a corneal wound, but it's usually not preferable because these are not self-sealing wounds and they cause a lot of astigmatism. So a scleral tunnel is always preferred. And the tunnel has to be at least 6 millimeter wide, because the PMMA optics are usually 6 mm in width. And therefore, we should not make a small scleral tunnel and try forcing the IOL out of the tunnel, because that usually there are chances we might create a descendant membrane. There are chances we might do corneal damage. So we should always make a liberal 6 mm scleral tunnel. And whenever we are expanding the PMMA IOL, we cannot place an IOL in the sulcus, because the PMMA lens has to be expanded as a whole with the bag. And therefore, we should plan a scleral fixated IOL or an AC IOL in these cases. So this is a scenario where the case where the PMMA IOL was a 1 month old surgery, and one of the haptic was out through the SICS wound, and the other haptic was in the AC. So there was no signs of any wound site infection or endophthalmitis, and the plan was to reposition the same IOL in the sulcus. You can see there's a hole in this IOL that signifies it's a PMMA IOL, and it's always a good idea to have a good view. Therefore, you should use iris hooks whenever desired. And therefore, iris hooks were used, the sulcus was evaluated, and the IOL was rotated back into the sulcus, and anterior vitrectomy was done to clear the vitreous in the anterior chamber, and the posterior vitrectomy was also done to clear the residual cortex, and also there was dropped cortical matter in this case. So you see this PMMA has been repositioned into the sulcus, and this was how it looked post-operatively, and the patient did fine. Now, IOL exchange post-YAG capsulotomy is another different scenario where there is already, you've done a YAG capsulotomy and now you have to exchange the IOL. That is, move the IOL and perform, exchange it with another IOL. So in these cases, we usually have to perform additional vitrectomy, and sometimes you also prefer past-planar vitrectomy in these cases. So we can replace an infusion cannula in the either peripheral clear cornea and a port in the past plane and do the vitrectomy. Because since the patient already has a posterior capsulotomy, there's an open communication within the entire group, so we don't have to necessarily place an infusion via the past planar. But the best sequence is that you should place the trocars well before doing all of these IOL exchange maneuvers, because once you remove the IOL, the eye becomes soft to get the trocars in the right position. So you should place the trocars when the globe is well formed, cap the infusion port off, and then do all your anterior segment manipulations, remove the lens, then do your vitrectomy, and then finally place the new lens in the sulcus. So now let's look at this. So this is the same sequence. Now let's look at the next scenario where we have to where there's a toric IOL which is off axis. So how do we evaluate the rotation of toric IOL? Although it's a different class altogether, but I'll just give you an overview that subjectively we can see that the slit on the slit lamp, the desired axis is the same as the axis in which the IOL is placed, or objectively we can also measure it using an eye trace wavefront aberrometry. So the best timing to reposition a toric IOL is between 1 to 3 weeks, because it's easy to reposition the IOL. And in late cases, obviously, there is again the risk of zonular rupture because there is firm fixation of the IOL with the capsule. And with toric IOLs, according to the study, a realignment procedure is usually necessary in 1.68% cases. So again, we do the same thing, open the previous corneal incisions, inject OVD, and rotate the toric IOL into the desired position, confirm the alignment of the IOL axis, and then the incision is hydrated. But more important is you have to completely remove any OVD, because any residual OVD might later, when it gets cleared, it might lead to some IOL rotation. So this is one surgery where the we're doing a Callisto assisted surgery. So basically it's so we can see the axis. This is the desired axis, 2-degree axis, but this is the axis of the IOL. You can see these 3 dots on the IOL tell the axis of the toric IOL. So this is a off axis toric IOL. So again, the previous corneal incisions are open. We put a lot of visco below and above the IOL. We try to rotate the IOL. Actually, not below the IOL, above the IOL. We try rotating the IOL into the desired axis. You see, the surgeon is using a manipulator to rotate the IOL into the desired axis. And now, once the 3 dots are aligned with the desired axis, we're doing a visco aspiration. All the visco is aspirated from around the above and below the IOL, and then the wounds are hydrated. So this is another surgery. Now, as I said, sometimes you have to remove the IOL through the SICS wounds. Either an IOL which is a PMMA IOL, that has to remove with an through an SICS wound usually. So in this cases, we are already planning that there is no capsule support. So we are already planned that this patient will require a scleral fixated IOL. So 2 scleral flaps are made 180-degree apart, and you can see scleral flaps are being created. We do a pass because the IOL is almost hanging in the vitreous cavity, although it can be expanded through the SICS tunnel. We first clear all the vitreous around the IOL, even though that might mean dropping the IOL in the posterior cavity. So this is basically for a posterior segment surgeon. For such cases, you always need a posterior segment surgeon to perform these cases, because even though the SFIL can be done by an anterior segment surgeon, removing of this dropped IOL would need a retina surgery. So you make a SICS tunnel, you clear the IOL incision, IOL adhesions to the vitreous, bring the IOL up in the anterior chamber and remove the IOL very smoothly through the SICS tunnel. And when you now the only option is you put a MA60 AC IOL as a scleral fixated IOL. So now that you've already had an SICS tunnel, you would insert the IOL through this tunnel in an inverted S shaped, and this is the Gibbons technique of they're using IOL holding forceps. They're using an end grasping forceps to get the IOL haptics out of the scleral tunnels, scleral ports 180-degree apart, and then the IOL haptics would be fixated in these scleral tunnels. So these are cases where you require a retina person to handle the case. So whenever you plan an IOL exchange or an IOL repositioning surgery, I think every surgeon must know how to create SICS tunnels, because that is really important whenever you're taking up a patient for IOL exchange, you never know when you might need a SICS tunnel to expand the IOL. So this is placed in the as a scleral fixated IOL. This is another surgery where the IOL exchange is done through the SICS tunnel. This is basically a 3-piece IOL, which is hanging. One of the haptic is fibrosed in the back. However, the other haptic was hanging in the posterior chamber. And so pars plana vitrectomy is done. All the vitreous is cleared around the IOL. And because clearing the vitreous around the IOL before trying to explant the IOL is very important, because if you don't clear the vitreous and try to pull the IOL, all these maneuvers can create bigger problems, which is traction to the vitreous and creating retinal breaks. So you don't want to create a retinal break and leave the patient a fake kick. So you better do a good vitrectomy before you try explanting the IOL. So this is a 3-piece IOL. Although this, I think the haptics were broken in the from the edges. That is why the surgeon did not try to reposition the same 3-piece IOL. Although this 3-piece IOL, when it is dislocated, can be repositioned as an SFIOL. But here the surgeon planned to put another 3-piece MA60 IOL and through the SICS tunnel. And again, this is taken out of the scleral flaps 180-degree apart and refixated in the, and the haptics are inserted in the scleral tunnels and the flaps are closed with them. And the SICS tunnel is also closed. So this is a good rehabilitation of the patient. This is another case where there is the patient had already had an SFIOL, which was a sutured SFIOL. And with SFIOL, there is always a chance of, suture erosion and the IOL dislocating back into the posterior cavity. So this has happened in this case, that in one of the haptic has, the suture has broken, and the haptic has, and the IOL is hanging in the vitreous cavity. So now because this is a this is a sutured IOL, and this haptic has an eyelet. So through this eyelet, we again pass a suture and refixate the same SFIOL. So in this case, this is a 90 Prolene suture is passed through the scleral tunnel, and a 26 gauge needle is used to take the needle out of the opposite end. And again, the needle is the 90 Prolene suture is passed through from the opposite paracentesis. And again, you will see that the 26 gauge needle is inserted from the scleral port through via a different site, and the needle is passed through, and the Prolene suture is passed in the needle. And it is again brought out through the scleral bone. So this way we secured this haptic back through the sclera, and the suture is tight, and so this haptic is secured. We suture it, we pass 3-4 ties to make sure that the suture is tight, and then we complete the rest of the vitrectomy. However, when the rest of the vitrectomy was done, we noticed that the other haptic also dislocated into the posterior cavity, and you see the other haptic is also going down, and when the vitrectomy was done, this haptic also dislocated. So the similar procedure was done to secure this haptic again. The 90 Prolene suture is passed through the eyelet of the haptic, and the 26 gauge needle is used to bring it out of the opposite end. This 26 gauge needle is passed through the AC paracentesis, the corneal wound. And then again, the 90 Prolene suture is reinserted, and again, out through the 26 gauge needle through the scleral port, and the suture is tight, and the SFIL is resecured in its place. So sometimes we can refixate the same IOL. So we should try and refixate the same IOLs whenever possible. But of course, if we cannot do that, if the haptic is broken or any such case, we have to put a new IOL. So this is another case where there is a the patient already had an IOL in place. The patient also had another dropped IOL in the posterior, in the vitreous cavity, and that dropped IOL was a 3-piece IOL, and the haptic was the haptic had caused a retinal break and a subsequent retinal detachment. So that IOL had to be removed. So the technique plan was through an SICS tunnel. So you can see an SICS tunnel was made. So the patient had 2 IOLs. One was already secured in the sulcus. It was a PMMA IOL. You can see the hole in the optic. And so this is the retinal detachment. You can see once the surgeon starts doing the vitrectomy, he sees there is a IOL with the 3-piece IOL with the haptic embedded in the retina. So a 3-piece IOL, these 3-piece IOLs are usually dangerous. They have more chances of causing retinal breaks and detachments. Usually single-piece IOLs have less chances. So sometimes patient have a single-piece IOL from a long time in his vitreous cavity and there is no complication. But a 3-piece IOL is a little dangerous, and this has to be taken out. So there is this 3-piece IOL. So the IOL is first taken out of the from the haptic is disengaged from the retina. The IOL is freed. Vitrectomy is done around the IOL. The IOL is brought into the anterior chamber, and we realized, and the surgeon thought that when he brought the haptic in the anterior chamber, there was some sulcus deficient, and through which the whole of the IOL could be brought into the AC. So without disturbing the pre-existing IOL, which was in the sulcus, the dropped IOL was brought in the anterior chamber, and very easily it could be removed through the SICS wound. So we did not disturb the other IOL, which was in the sulcus. So the patient was not left faking in the end. So it was the cornea was absolutely okay, and we could remove the dropped IOL. The surgery was completed, and the retinal detachment was settled, and oil was placed in the vitreous cavity. So we see in all these cases of IOL refixation, repositioning, or explantation, the most common intraoperative complication is anterior vitrectomy, because a lot of time when we are manipulating with the IOL, we are trying to get the IOL, the PCLs out of the bag. We have PC rents pre-existing, or there is a zonal adhesions through which vitreous comes in the anterior chamber, and we should be prepared to do anterior vitrectomy. And of course, risk is greater in patients who have a pre-existing PC defect or who have already undergone GAC capsulotomy. The second most common complication is actually zonal adhesions, because whenever we pull these IOLs, inadvertently, we end up sometimes causing zonal adhesions, and we actually lose the sulcus also. That is why we have to be very patient when we do these surgeries. We have to take our own good time. And usually these surgeries should be done in the hands of experts. And you should put a lot of OBD, take time, not try to pull the IOL out of the bag. If we should not try to be very vigorous. And if we cannot get the IOL out of the bag, we should be content with cutting the IOL at the IOL optic haptic junction and leaving the haptics in the bag. And sometimes these leftover haptics can also dislocate in the optical axis or in the vitreous, or might interfere with the position of the new IOLs. As I said, that's why whenever we try placing a new IOL in the sulcus, we should always try and orienting the haptics 90 degrees to the pre-existing haptics. Any surgery to reposition or exchange any posteriorly dislocated IOL can have post-op complications like a cystoid macular edema and retinal detachment. Even pre-existing, so whenever there is a CME, we try and delaying these surgeries. So these surgeries are usually done when the patient is complaining of dystopsias, or the patient is problematic. Sometimes even when the IOL is malpositioned or is decentered, we don't try to touch the lens if the patient is not having any complaints. If the patient is happy and comfortable, we try not to touch the lens. Only when the patient starts complaining or there is a complication associated with these IOLs, we try and plan these surgeries. Because because the IOL in the bag is the best scenario. So any IOL which is not in the bag has some complications. So like IOLs is placed in the scleral fixated IOLs have obviously these complications of IOL dislocations, loosening of the sutures, erosion of the haptics, scleral thinning, retinal detachments, and there's a high rate of additional surgery. And of course, with the anterior chamber IOLs also, there is risk of more higher risk of PBKs and glaucoma. So to conclude, IOL repositioning or explantations can work as highly gratifying surgeries if they are done properly. However, and these surgeries, the need for surgery, as I said, is hugely dependent on patients' expectations and not alone on the examination findings. We should be very, as I said, patient counseling is very, very important. And you should talk to the patient, ask what is a problem that he's having and whether we can address this problem with the surgery. If we cannot address the problem with the surgery, then there's no point of doing a surgery. And we should never hesitate to refer these patients, especially as beginners and as postgraduates. If you have a patient you operated upon and then the IOL is decentered or subluxated, you should not hesitate to refer the patient to an expert surgeon and not take the patient again, because usually when these are secondary procedures, patient has high expectations. You cannot, try on these eyes. You should always, I think these surgeries should be done in the hand of experts only. And these are very demanding patients. Therefore, do not hide anything from these patients. Counsel them very well about the present condition, any risk involved, what are the post-op complications, and of course, the cost involved. And of course, you should always have a good retina surgeon. It's always good to have a retina surgeon as a backup while performing these surgeries, because you never know when you lose the sulcus, when you cause a zonal dehiscence, and you might have to, if you're not good, if you don't have an ACIL backup, you might have to do a scleral fixated IOL. So you should always have a retina surgeon as backup. I would like to acknowledge Dr. Gaurav, Dr. Avnindra Gupta, Dr. Garvita, Dr. Shweta, Dr. Bhanupriya, and Professor Amandeep sir for their cases and for their help. Thank you.
Thank you, ma'am, for the lovely presentation. I want to invite the chairperson, sir, and Dr. and moderator, sir, for their expert comments, please.
First of all, I'll like to congratulate Dr. Nikita. She has presented very well. She has covered all the details in the videos, all the techniques, how to remove the IOL and how to reposition the IOLs. Few words, I think, which have been missed out are on basically misaligned toric IOLs. So toric IOLs, first is the precaution is very important, especially if you are doing the manual marking. And when you are taking the readings on the optical biometer, the patient's head has to be straight. That you have to be very careful. Then we should have reproducible values. There should not be any dry eye. We should see that the patient is having a good, the tear film should be good. Second is when the patient is in the OT, if we are using a bubble marker method or a slit lamp to mark the 0-180 axis, again, the position of the head is very important. If there is slight head tilt, everything will be like wrong. Then during surgery, the removal of viscoelastic behind the lens in toric IOLs is again very important, because if there is some amount of visco left behind the lens, the rotation of the IOL is likely to occur. And then the last slide, so we have to take our IA probe behind the IOL to remove the viscoelastic. And the last thing during surgery is that the wound should, the AC should not be too deep, the eye should not be very tight. Because if it is a deep AC, again, the chances of rotation in the immediate post-op period are very high. Now coming to, suppose we have a misaligned toric IOL, as has been rightly said that the time period is 1 to 3 weeks. But once we know that we have to realign, then which formula to use, how to calculate the new axis, and whether the same IOL has to be realigned or we have to remove the IOL and we have to exchange the IOL. So if the power of the IOL is like, if it is a minus cylinder and a plus, like basically +2 and -3.5 cylinder, something like this. So then we can always try to reposition the IOL. But when there is a minus sphere or a plus sphere and a plus cylinder, then we need to exchange this IOL. The formulas are astigmatismfix.com, and nowadays Barrett RX formula is supposed to be better because it takes into account the PCA and also the AC depth and ELP of the lens while calculating the new axis of the IOL. So this was about the toric IOLs. Briefly, I have just mentioned what was left over. And then one thing that once the IOL has been taken out and now we are putting a SF IOL or a AC IOL, the new IOL that nowadays we are using are posterior iris claw IOL. If the pupil is round, do a proper vitrectomy, and if you place a posterior iris claw IOL, it really saves a lot of time and it is really giving very good results to us, at least in our hands. And it is not in the anterior chamber, so it is not causing any of the corneal endothelial damage and all. I think three-piece dislocated IOL, if the loop you can bring and you have a support of the anterior capsule, you can always place it over the ciliary sulcus, in the ciliary sulcus, and if possible, do a posterior capture of the optics. Otherwise, the all other techniques have been very nicely shown in the videos. I think that's it. Dr. Prafulla can add.
Thank you, sir. I think Nikita covered all the videos showing all the techniques, and also you highlighted all the important points. But Nikita, I think for postgraduate, the common questions that will be asked to them in exam is when to decide, when to take a call, whether this IOL should be repositioned or leave it like that. I think in chat box also there is a questions related to this. When would you take a call? Even suppose the IOL is decentered, but patient is still having vision 6.6 or 6.9, sorry. Then would you like to intervene, or what are the factors that you will consider before planning to reposition that IOL?
So as I said, I don't think if the patient is not having any complaints and the IOL is decentered, we do not want to intervene because, as I said, uh, if the patient is happy, so I think we should not intervene. Only if the IOL is obviously off, not in the pupillary axis, or obviously then the patient will complain of a drop in vision, or the IOL is creating some problems, as in it is causing cystoid macular edema, or it's causing persistent inflammation, or a glaucoma, or it's damaging the cornea. Only in these cases, I think we should remove the IOL. Otherwise, I think this should be very well on the patient's complaints. I mean, we should make the decision after talking to the patient, and if the patient is not happy, not unhappy with the decentered IOL, we should leave it as such.
Yeah, I think that was the question by Dr. Tulika Srivastava. I think we answered that. So, what are the parameters that you'll consider before proceeding with surgeries? For example, what should be the specular cutoff? What should be the corneal thickness? Are there any parameters that you'll consider before going ahead with the surgery?
I think post-cataract surgery, already the spectra would be less, but I think it should be above 1,800 to 2,000 before we take up the patient for surgery. And what was the other thing? As a corneal thickness, again, it should be not more than, I think, 550, 560. I'm not sure if there is any set parameters, but I'm just saying out of experience.
Yeah, there is no access. I think the question is by again same. So the answer to this lies in the fact it's ideal to send it to a corneal surgeon, because the only problem with operating in IOLs with borderline specular all or increased corneal thickness, say 520 is your healthy eye and this eye is 540, there is a possibility that after surgery the cornea may decompensate or the endothelial may fail. So the patient may need a second surgery in the form of endothelial keratoplasty. So if somebody is having borderline parameters like specular count is say 1200, and it's ideal to take a cornea consult. What we do at RP center is in all these cases where we expect the cornea may fail, we register them for DSEC or DMEC and then proceed with stage 1 IOL explant or IOL replacement surgery. And if you do that, then the patient is already counseled for the consequence. But I have seen a lot of cases referred to a secondary IOL done, then the patient is after the surgeon's life because of corneal decompensation. And the only drawback in that was the patient was never counseled that you may need an endothelial keratoplasty subsequently if your cornea fails. So patient counseling in all this secondary procedure is important. The third question is, Nikita, this
And
is
so,
the
if I
age
may
of
add, in these cases, we should use a lot of viscoelastics also while performing the surgery, so that we protect whatever endothelium we can
Viscode
utilize.
dispersive specifically, Viscode
Yes.
for residents, and yeah, I was asking something, I forgot that.
Question.
Garvita, you may
I'll
proceed
like
with the
to
questions from audience. If I
I'll
recall
like
what.
to add one thing in the first question. You said that the vision is 6669. So here we have to see that which IOL we are dealing with, whether it is a multifocal IOL decentered or a normal monofocal IOL. Then second thing is we have to see the mesopic sizes, like mesopic size, pupil size. And then we have to check how much decentration is there. And we have to also ask how many dysphotopsias, positive dysphotopsias patient is complaining of. So it is not only the vision that matters. There are other things also which we have to take in combo and then decide whether we have to remove this IOL or do some surgery or not.
Yeah, I think Nikita exactly answered this the same way. But the question was that the patient is asymptomatic. That was the question.
Asymptomatic, then yes, he is absolutely right. Then we can have the
Any
question.
other questions, Garvita, from audience or
Yes, sir,
students?
we have a bunch of questions, sir. First,
Please go to them.
first was, if the patient has IOL bisecting the pupil, but the patient is asymptomatic, do we need to explant the IOL and implant a new one, which is discussed?
Again, I think the same thing. We will not
Yes.
because the patient is not
But
complaining.
whoever the student, Garvita, you have to, I think first you have to assess, even if the IOL is bisecting the pupil, why the patient is not having any problem. One possibility, there may not be any visual potential at all. If the patient is having visual potential, then he or she is bound to have issues. If your lens edge comes, that you have two areas of refraction. One is aphakic, one is phakic. So it is bound to cause problem. If in spite of people bisecting IOL, the patient is asymptomatic, that means either the patient is ignorant, he's not bothered about the eye, which is most likely due to poor vision in that eye.
Even if the patient may not complain of low vision, he or she will complain of glare and
Yes, some problem will be there. Definitely
yeah.
some problem will be there if pupil is bisected by your optic edge.
Right, sir. The next question is, can we replace IOL in the bag if there is a small PCR after IOL explant?
I think in the second surgery, whenever we're doing a second surgery, if there's a pre-existing PCR, there is no point of placing IOL again in the bag because then we might have to do a lot of vitrectomy and then the vitreous will keep coming from the PCR. I think as a second surgery, we should sometimes whenever we are doing a cataract surgery and there's a small PCR, we can still place the IOL in the bag. But when we have to exchange the IOL or refixate the IOL, then I think as a second surgery, we should not place the IOL again in the bag. We should, I think, place the IOL in the sulcus only. So,
So
any
the
thoughts?
question is, if the PCR is small,
So you can convert it into a posterior capsular axis if
And do
possible, and then implant in the bag.
at times, yeah, people do that.
Okay.
Just like post-polar cataract, you can try to convert it on a circular axis, in the post PC, and you can put the IOL. But as Nikita said, most of the time it's very difficult in second procedure. Primarily, you are doing surgery, there is a rent, you can do a PCCC and convert it and put the IOL in bag. But as a second procedure, at times it's very difficult. Questions? Any questions, Garvita?
Yes, sir. The next question is, how to calculate the power of IOL when placing it in sulcus?
I think last class,
think-
Nikita, let me just add something. I think Garvita, last class there was a good discussion on this, right?
Yes, sir. Yes, sir.
Secondary,
We did cover
uh,
it.
I forgot the surgeon's name, but she gave us a good nomogram for that.
It's a rule of
And
9. Till 9
yeah, so,
diopters, we do not change the
yeah. The
Yes.
same
9 to
nomogram. I think you can go back and carefully go through that slide, whoever the student is, and you should follow that nomogram. Nikita, if you want to add anything, you can add.
So I'll just only answer the question that, yeah, as you already said that the nomogram is still 9, you don't change the power of the IOL. From 9 to 18, you subtract 0.5, and for 18 to 27, I think you do subtract -1. I mean, you decrease the power of the lens by 1. And of course, you should also know for an AC IOL, you have to use the A constant of 1.5.3 and then calculate the power of the lens.
There are set of nomograms. I think one should follow that. and few people just adjust by from their experience. But for students, it's always to go through the literature and then do all these things. So one more question, Nikita. All the second procedure, the risk of end-off is almost double that of the primary procedure. So what are the precautions that one should take before going ahead with the second intervention within 1 or 3 weeks?
So I think if we are making the we are doing it in the first 3 weeks after cataract surgery. I think we should I think if you're making corneal incisions, the risk is less. Of course, if you're doing an SICS, making SI tunnel, the risk is higher. But the thing that we can do is give antibiotics for a longer duration, the post-topical antibiotics, I mean. And of course, I don't think there'll be any extra precaution other than just giving the drops for a longer period. Of course, we'll have to have a look. We should have a lookout for prolonged AC inflammation or any vitreous haze. That is the only thing I think. There's no extra precaution as such.
Any comment, Neeraj sir? What's your experience and any specific precaution you take to
I
prevent
think,
infection?
I think intracameral, if you are not regularly using and in your routine cases, in this type of cases, definitely you should use intracameral Vigamox or
Yes,
moxifloxacin, whichever brand you want.
that's a must. That's a must in
Okay.
all these cases. And betadine clean, I have seen people, even I also do that. Just put some betadine and wait for 1 or 2 minutes and then go ahead with surgery. The problem, the concept behind this is that once you have operated, there is a leaky channel, or there is you have broken the natural barriers, right? That is one. And second, you are giving steroids. Patient is already on steroids, so local immune flora
Yeah.
is altered. And so that these are the factors that may increase the risk of infection. Although if you go through the literature, there are very few case reports suggest secondary or say repeat procedure carries high risk of infection. So keeping betadine little bit longer, all this thing may help you. But
So I think so
intracameral
as
moxifloxacin is a must, as sir suggested in all these cases. If you are not injecting in routine cases, please in all these all these procedures you should inject. I said, Nikita, you are not fond of using intracameral tricot, yeah?
so yes, of course. If there is vitreous in the AC or in the wound, we should always use
In none of
intracameral
your video ever, whichever video you showed,
because
I think you ever did using tricot.
I think I did not show a video with the PC rents, and I think
The same with
those,
me also. I also very rarely use that, but that's a good addition for
yeah, I
novice
agree. And
surgeon
especially for beginners,
beginners.
yes.
And it's always good to inject tricot, because if you leave some little bit vitreous strands, then there may be retinal problem, IOL decenters, and all this thing can be
And
there.
as beginners, it's always difficult to identify vitreous in the AC or in the wound intraoperatively. So yes, tricot is a good
True.
option. And so intracameral moxifloxacin actually in CFS as a routine we all give, and I mean routine cataract surgery also. So I think that is taken. And of course, I think betadine cleaning in even routine cases as postgraduates should always keep that 3-minute window after cleaning with betadine, so that anyways you decrease the risk of infections postoperatively.
And if you're a beginner, then it's always good to check the wounds. For example, the primary wound, if you're doing the second procedure for the same wound, please check for leaks. Even if there is a little bit leak, it's always good to put suture.
There was one video, Dr. Nikita, in which you showed that the PMMA loop was outside from the wound. So I'd like to ask you that I think while we are doing a teaching session to the residents here, uh, my personal opinion will be that I'll not like to put this IOL back. I will better to remove this IOL and exchange this IOL. What is your take, Dr.?
Yeah, true, sir. True, sir. If although PMMA material, no, it's very rare that there is some colony formation, but you can never rule it out. Okay, so we don't know, some bacteria might have inoculated that surface. So it's always a good idea, if any part of IOL is outside eye, then please take it out. Just like our iris, right? Any iris which is more than 24 out, we cut it. We don't reposition it. The same concept with IOLs also. If it is out, then it's better to take it out.
So I agree, sir. I do agree. And this was the first option given to the patient that we would explant this IOL, but the patient was hesitant that this IOL, we I'll not
Yeah,
get another
that
IOL in the eye, and then we rule out any sign
yeah,
of
this
infection.
happens. This happens with the patient. Patient at times they say, no, I want this IOL.
Any other questions, Dr. Garvit?
Yes, sir. We have some more questions, sir. What is your preferred technique for SFIL, ma'am?
So I prefer the Gabber's technique where we make scleral flaps and tunnels, and we take the IOL out through the IOL holding forceps or the 26 gauge needle and then put it in the tunnels. So I don't do a Yamanis very often, which is a transcral. I think, again, as a sir said, there is the techniques that I discussed previously. But yeah, I prefer the Gabber's technique.
Okay. Next question is, please elaborate material for secondary IOL selection.
So the material for secondary IOL is the question is where you're planning to place the IOL. Are you planning to place, is the bag PC intact, and are you planning to place a new IOL in the bag? Then you'll take your own, and then if the surgery is done in the early post-op period, then you'll choose another monofocal acrylic single piece IOL. If you're planning in most cases, as you have to put an IOL in the sulcus, it's always good to have a 3-piece IOL to place in the sulcus. You don't want a single piece IOL in the sulcus for the risk of UGH syndrome. So you prefer a 3-piece IOL. And for an SFIL, you can use an oral PMMA IOL, or you can use a 3-piece MA60AC IOL, any IOL that, or a sutured PMMA IOL, which is, as I showed, which is eyelets in the haptic. That is, yeah.
I think the question is whether you prefer a PMMA or a hydrophobic acrylic or hydrophilic acrylic for secondary choice.
Is the material that they
I think
ask
it's a
for.
PMMA should be preferred because it has more stability.
I think
What is it?
Why would you prefer
there
PMMA?
is no
If that's-
hydrophilic.
Sorry, so if the question is any position, which material you will prefer? Is that the question?
They are asking the question is which material you would prefer. Suppose you have a choice of both PMMA as well as hydrophobic acrylic. Which one
No,
would you
then
prefer?
we'll prefer the hydrophobic if that IOL can be placed.
Yes, I think this is a basic question asked to students in round. See, quality of vision wise, PMA is best. But if you want to put a PMA, you have to enlarge the wound, make a
Yeah,
5.5
obviously.
incision. But a 3-piece lens, you can inject through a 2.8 incision or 3.2 at most. So, because for that advantage only, we prefer hydrophobic acrylic. But if some device comes and your PMA can be injected through 2.2, PMA gives you the best color and contrast vision. So that is preferred. But at this stage, we don't have IOL which can be injected through a smaller incision. So all of us would agree we prefer hydrophobic acrylic 3-piece lens for secondary IOL implantation.
Right, sir. Next question is, how can you manage the optic haptic angle?
I think you are how can you manage? No, the company has already created the IOL with a 5-degree angle. Some lenses are 15-degree. If you put it in correct orientation, that will automatically manage itself. Surgeon cannot do anything.
Right, sir.
For sulcus, of course. But for SFL, I think Nikita, you have to answer that. If you are doing SFL, how will you manage that angle? Probably that is the question. I think, Garvita.
I think for SFIL is the only thing how we can ensure that the IOL is the optic haptic angle is maintained is, I think, mark the 180 degrees. Do not do it by estimation. Mark the 180 degrees angle, 180 degree position, and the the scleral port has to be made 1.5 mm from the limbus on both the sides, and it has to be
So that is the trick.
equidistant, and
The scleral port has to be equidistant and the thickness of the flap has to be equal. Then that will ensure that your SFL is in right position. And angulation doesn't matter in SFL because you are putting behind the iris.
Right, sir. The last question is, which techniques are preferred for removal of 3-piece IOL in traumatic cases?
Traumatic case means is there any specific problem associated trauma or routine, just like routine trauma? Then for routine trauma, as Nikita already showed you all the techniques. So which is your preferred technique? I think that is the question, Nikita. Which is your preferred technique and why?
for removing a 3-piece IOL.
For removing
Yes.
any IOL post trauma.
So if the IOL is a single piece IOL, my preferred technique is to as I showed, to cut the IOL optic into half, and up to the radius, and get the IOL out of the bag. If it is a 3-piece IOL, I usually try to scleral, and if the IOL is intact and with the haptics, I try to scleral fixate the same IOL or put it in the sulcus, of course, if the sulcus is present. So yeah, that is how I remove the IOL.
I'll just put a question here. Suppose there is a trauma, there is a perforating injury, and there is a large cut in the cornea through and through. So, will you remove the IOL from the corneal cut itself, or you will again first suture the cornea and then put a viscodispersive, viscoelastic, and then remove it?
I think the best way is to first suture the corneal wound and do it as a second procedure. I don't think we should remove any IOL through the corneal wound, even though it is a smaller or a large wound. I think we should do a primary repair of the corneal tear, and then as a second procedure, remove the IOL.
Yes, because the student need to understand this. It always it's very easy to pull it out so the cornea don't. But if you try to do that, you will put a lot of traction on the vitreous, and that is going to create a lot of trauma to the retina and that una serrata area. So you may land up in posterior segment complication. Vitrectomy is always good in as a closed chamber procedure. So ideally suture the wound, then do a good vitrectomy, then take the IOL out. Don't pull the out without doing vitrectomy, or else you'll create a lot of traction and posterior segment complications. But there are situations, there are cases that comes to us, the IOL is already half in the wound. And in those cases, you cannot do anything. You have to take it out, then suture the wound.
Because as you said, anything out of the eye already does not have to be pushed inside.
Your take, sir, Neeraj sir?
Right, that's it. That's what I said, that if it is still inside the eye, you have to suture and go the way. But if it is already a very large cut and the IOL part is outside, or it is stuck in the cornea, it is better that you just pull it out through that. So that all depends that how much scarring is there in the bag, the optic, how much it is out. So you have to assess the position on the table. But if the corneal wound is clean cut and the IOL is nowhere near or is not stuck inside, we need to suture the wound, put a viscodispersive, and use the techniques as described to remove the IOL. But we
Nikita, any experience of
may need a PK later in such cases.
Nikita, any experience of bag fixation?
I haven't personally done any.
Yeah, but in all the difficult at times it works. Post-traumatic, your single piece in bag and there is some trauma and your bag is displaced little bit inferiorly, superiorly. You can fix the bag also. All that's quite challenging, but still you can do that. Garvita, any questions?
No, sir, these are all the questions, sir.
Okay, I think we should conclude here.
Yes.
Thank you, sir.
Okay, thank you all.
Thank you, Nikita.
Thank you, sir.
Wonderful. Thank you, sir. Thank you,
Thank you.
Garvita, as always.
Thank you.
और मेरा